It's expectant moms, people living with disabilities, and older adults. It is possible. I know we have Medicare, but you have to pay into Medicare for basically 10 years. That's a whole other webinar. We won't do that one today. Okay. So 50 years pass, and along comes the Affordable Care Act. And the Affordable Care Act says, you know what we don't do is we don't just cover people who are low income. So the Medicaid expansion, otherwise known in New Hampshire as Granite Advantage, was born. They are the people in yellow. So this is a weird slide that I created. It shows a variety of different New Hampshire Medicaid eligibility groups and all of the different income ranges that apply to them. Everybody's income eligibility threshold is different depending on which door you come in through. So low income adults, 19 to 64 years old, who aren't otherwise in an already eligible Medicaid category, right? And they have income up to 138%. They may have income up to 138% of the federal poverty level in 2026 terms. That's for a I think Jake said something about a lot of these folks are working because you can have a minimum wage job, work full time, and work every week of the year. And your income will fall below 100% of the federal poverty level, let alone the 138, right? So a lot of folks are working and still financially eligible for Medicaid through the Medicaid expansion. A lot of them are in jobs that they don't routinely offer part-time people health insurance, or they don't traditionally offer people health insurance at all because it's seasonal work, right? Like the guy that plows the driveway, right, or the landscape. Okay. So these are the folks that the Affordable Care Act introduced coverage for. So the reason this is important is that I missed one of my main talking points. Hold on. So it's a publicly funded health insurance program for low income people. This is the vast oversimplification of this program. A state doesn't have to have a Medicaid program. But if it chooses, if it elects to have a Medicaid program, there's certain federal rules it has to follow. And really, truly, this is the most oversimplified thing I'm ever going to say about Medicaid. You have to cover certain groups of people. They're called mandatory populations. And you have to offer them certain coverage for certain healthcare services. Those are called mandatory services. In exchange for following those baseline rules, the federal government always pays a fixed percentage of the cost. And that is fixed, it's called FMAP or FFP, Federal Financial Participation. That percentage is never less than 50%. And it's meant to be countercyclical so that a state can always rely on that they know what the feds will pay, no matter what is going on in the enrollment of the program. So, for example, Medicaid has turned out to be incredibly flexible and helpful for when the Medicaid rules grew, when there was an AIDS crisis, when there was the great economic downturn of 2008 and 2009, when there was a pandemic, right? The federal government always pays a fixed percentage of the cost. It's always at least 50. What's really important here is that sometimes it's more than 50. And for these groups of people right here, it started out being 100%. Federal government paid all of it for first 3 years, and now it's gradually come down. It's 90%. That's in federal statute. Okay, Congress has to act to change that, and they've never done it. So the federal government pays 90% of the costs of coverage for this group of 50-odd thousand people. That's why when Jake says that Medicaid expansion is responsible for bringing $3 billion federal dollars into the state, that's why. Because the vast majority of those dollars are coming directly from the federal government. There is a state share. The state always has to pony up its side. So in the case of these folks, it's 10% of the cost of their care. For everybody else, it's whatever the other one is. Like for breast and cervical cancer folks, their match is 65, so the state only has to come up with 35. And for some of these other folks, it's very traditional, 50%. Okay. So, publicly funded, jointly administered between the states and the federal governments. Feds always have to pay a fixed percentage. We added the Medicaid expansion grant advantage folks in 2014. The reason I'm telling you this is because of that overwhelming federal responsibility for the payment of their services. The expansion group is the primary group that is going to experience most of the changes that we're going to talk about tonight in terms of what's changing for their eligibility. There are also a host of other changes that are happening that are about what the state can do in terms of how it can pay providers and what it can use to generate the state share or the non-federal share. That is a really important topic, but it's not as directly impactful to enrollees. And we wanted to start out, Medicaid Matters wanted to start out talking about what was enrollee facing first, limiting reimbursement to providers beyond limiting enrollment for folks is going to create a lot of financial pressure for the Medicaid programs. And so we could do another, when you guys are all like unable to sleep, we can do another webinar on this. And we'll talk about state directed payments and all other kinds of cool stuff. Okay. Okay, so in January of this year, this is what the population of New Hampshire Medicaid looked like. And I attempted to lump people together in those same big categories that I showed you in that first chart. So, pound for pound, Medicaid, and this is not uncommon, is a kids program. The single largest eligibility category in New Hampshire Medicaid are children. They're about 50%, 49% of the Medicaid population here. The next up is the expansion adults. So these are the folks with the red slice are the folks that are going to be there, that are going to experience the most changes in terms of eligibility and enrollment. So that's another 50-odd thousand people. Pregnant women, low-income Medicare beneficiaries, others, about 11,000 may make up this light blue slice. We have a really tiny yellow slice. Those are kids that have essentially nursing facility level of care needs. And so they get services at home. There's about 1,100 of them in any given year in New Hampshire. And then we have our older folks and our folks who are living with disabilities as adults. Okay. So remember the red slice. The red slice is going to keep coming up. Okay. Went the wrong direction. Can I just touch the little arrow? Okay. So there are some new laws that were passed, both the state budget and a federal law last year that introduced changes, and they're all roughly on the same topics. So kind of good, I mean good in terms of what we have to remember. So basically the state budget applies premiums, so monthly payments for insurance to some Medicaid families are mostly in the families with children who have, in the Medicaid context, slightly higher incomes. There are premiums, again, monthly payments for coverage for those expansion adults, the red slice adults, and work requirements for the expansion adults. Again, I feel like I have to say this every time. Expansion adults in New Hampshire are also often referred to as grant advantage adults. The One Big Beautiful Bill Act was enacted in July of last year, and it has the same, some of the same principles, work requirements for the expansion adults. It's increasing eligibility checks effectively to twice a year for these folks, and then it applies some additional cost sharing, which is different than premiums. Cost sharing is like what you pay when you're at the claim service to the pharmacist or to the provider. It's different than the premium, which is generally what you pay to the insurance carrier on a monthly basis for your coverage. Oh, okay. So everybody should be really impressed with the upcoming graphics. Okay. So I wanted to have a visual way of saying these are the people to whom these changes apply. So let's start first with the state budget changes. Oh, too many buttons. set myself up for
That's
that.
okay,
Make
that's
such a big deal out of it.
Yeah,
And then-
not too hard.
Yeah. Okay, so the regular pie chart.
There you go.
Okay, so these are the slices of the pie for whom premiums are going to be applied. Okay, so these were in the state budget, and expansion adults are going to be charged $60 to $100 a month, um, depending on their family size. And I had been hearing over the last several months that they were going to implement this in the third quarter of this year, so that's next month. But at the last public meeting I saw of Medicaid, they said that they're considering getting legal authority. It's called a waiver and demonstration authority in order to impose those premiums. Because the state requirement for premiums doesn't quite line up with what that new federal law, the OBBBA, says about premiums. And federal law always wins. So in order to do what the state budget requires, they might have to get some waiver authority. If they do pursue that, that will take a significant amount of time. Developing a waiver application is a lengthy process. And then submitting it and negotiating with CMS, which is the federal agency that oversees Medicaid for all 50 states, that can take a long time too. So that time frame is to be determined. There were also premiums put in place for higher income CHIP families. So those premiums would be about $190 to $270 a month. And it's going to apply to about 10% of the kids in the Medicaid program. Again, the public representations I've heard are third quarter of this year for the application of that. And at the last public meeting I saw, they said that they were still working on their timeline. So to be determined. But when they do get applied, it'll be about a third of the expansion population, and it'll be about 10% of the CHIP family population. Okay, so let's go on to One Big Beautiful Bill Act. So this federal legislation added 3 things that are enrollee facing right away. Two of them occurred early next year. So the beginning of work requirements for all of the expansion adults. Doubling the eligibility checks. Right now they are once every 12 months. And now for this group of folks, it's going to be once every 6 months. And in those 2 things are happening at the top of 2027. The last thing is, I love this screen. You can tap on it. It's like not one of those grade school screens, you know? It's not vinyl, it's like actually a screen. $35 for co-pays for certain services. And a lot of services are exempt from this, but that will be coming online, I think, late like October of 2028. What we know about, the reason this is significant is that what we know about work requirements, we've tried them here in New Hampshire, a handful of other states have tried them, is that it's very hard to accurately communicate what the reporting requirements are to demonstrate whether you are already doing what the work requirements want you to do or whether you're exempt from the work requirements. In the state, the last time it did this, spent literally billions of dollars trying to communicate that to the affected population. And a third of the people to whom it applied were about to lose their coverage when the program was under law. It had to be discontinued because they were afraid of all the coverage losses. So it's expensive and it's hard to administer. And anything you put in front of enrollment, like you have to do this thing in order to enroll, any extra thing you put in front of enrollment, it makes it harder for people to get enrolled and to stay enrolled. The same is true for premiums. Most people, I think, are aware that across the country, health insurance of all stripes, commercial, employer-sponsored, otherwise, is feeling very unaffordable to a lot of people. And people avoid healthcare if they're worried about what it's gonna cost. This is also true for people on Medicaid. And so, if they think that they owe a payment, they may not go, right? If they think that they can be kicked off of the program for failure to pay, they may just decide not to enroll at all. The eligibility checks, we learned this also through our experience with the pandemic. During the pandemic, there was something called continuous enrollment because the government was like, we should let everybody who has insurance stay on insurance while we're trying to figure out what it is that we're dealing with. And New Hampshire Medicaid, like most Medicaid programs, saw its highest enrollment that it ever did when they stopped disenrolling people because they didn't renew their eligibility once a year. And as soon as the once a year eligibility checks went back into place after 3 years, New Hampshire Medicaid, again, like most states, lost a third of its enrollment within 6 months. Okay, so we know that eligibility checks keep people out because people are busy, right? And if someone's not sick on that day, right, it's not a fire they have to put out paperwork. Anyway, is often the issue. People also can have very fluid living arrangements at these very low income levels, and it can be just not the top thing that they're dealing with on that day. Okay. So these two things in particular are known in health policy literature to depress enrollment. So it's going to be harder for people to get enrolled and stay enrolled. Okay. Now that I've cheered us all up, some guidance came out from the federal government June 1st with some of the details about the work requirements. And this is fine print. I promise we will share this slide deck with everyone. So what CMS told us is that you have to work 80 hours a week, or you have to be in community service 80 hours a week. You can also be in an apprentice or an internship program for 80 hours a month, or you can have to be enrolled at least half-time in an education program, and you can be in a combination. There's going to be details about how you add up the hours and how you demonstrate that you're doing all of the appropriate things. Self-employment, gig work, all included in employment. The type of employment that is not covered, that will not show that someone has demonstrated that they have complied with the work requirement, are those Medicaid covers employment services. For community service, the detail is really that it has to be trackable. It has to be auditable. You have to have a way of demonstrating that the person did the work. And so the not-for-profit is going to have some way of attesting to and showing that they have oversight of the volunteer activity, that it's not for political purposes for a particular party, and that they can track it. So that someone could come in and say, show me all your work requirement records, and that they could then do that. There are, of course, exemptions to the work requirement, and there is a full list here. The one I really want to focus on is the medically frail, because that is in the statute, that's like a wide open definition, right? Medically frail or otherwise have a serious or disabling condition. And the details that CMS gave don't use the existing definition of medically frail that the Medicaid expansion used way back when it was first coming online. They've introduced a couple more layers of detail that are going to be really important because it's about demonstrating the frailty and not just demonstrating that the person's been diagnosed with a particular condition. For those of you that can't see them, I am going to read them really quickly. So the exemptions are former foster youth. Medicaid covers folks who were wards of the state but graduated from that when they became 18. Medicaid covers those folks until they're 26, parallel to the way that parents can keep their children on their commercial coverage until they're 26. Parents, guardians, caretaker relatives, and family caregivers are an exempted category. There were a lot of details about that. They're primarily really good. We're just not going to cover them tonight. Again, another webinar for sure. American Natives and American Indians and Alaska Natives, disabled veterans, folks that are receiving temporary assistance, cash assistance, and meeting that work requirement. Same for SNAP. People who are in a drug addiction or alcohol treatment program are exempt, but there is some fine details in there that we should talk about. If the person's been in stable recovery for 5 or more years, they will not be exempt from the work requirement. People who are living in a public institution and women who are pregnant or postpartum. Okay, so let's talk a little bit about medical frailty. So a person can be considered medically frail if they have one of these significant conditions. Blind or disabled, substance use disorder, again, the 5+ years of recovery means you're not medically frail. A disabling mental disorder, a physical or intellectual disability, and a serious or complex medical condition that has all of these qualifiers. The thing that CMS introduced that was new is that the state has to have a way of demonstrating that whatever that health condition is significantly impairs the person's ability to comply with the work requirement. That's new. So states are going to have to come up with a list of all of the conditions and diagnoses that they are putting forward as their medical frailty list. They're going to have to also come up with a way of showing with third-party data, so claims data and encounter data, what level of services the person has received the state considers to be evidence of medical frailty. So the state will have to create a list, and then it's going to have to say, and for someone living with HIV, someone living with HIV, there's going to have to be in their claims records. They're going to have, had 3 inpatient stays in 12 months in the last 15 months in order to be considered medically frail. I am making all of that up. No one has said that to me. That is just for illustrative purposes. I don't have any idea what the rubric is that the state is going to put together. Those lists and those metrics for demonstration all have to be auditable by the federal government. And there has to be a process through which an individual could say, my condition is not on that list of medical frailty, and I think it should be. And then they have to have a way to communicate with everyone what the process is for petitioning the government basically to include that condition on the medical frailty exemption list. Okay. So this is the fine print that I just told you about. It has to be auditable, and it has to be revised on a regular basis, and people have to be able to petition to get their condition added to it. And then this is the other the fine print I just mentioned. The state has to have a way of verifying the medical frailty. It's not enough that the diagnosis is apparent. There has to be some other metric in the claims data that this person's clinical experience justified. There are also requirements on the state for conducting outreach sufficiently in advance to enrollees. The notice period depends on how far back in the record the state elects to look to see if someone fulfilled the community requirement, the community engagement requirement, because in addition to demonstrating that you fulfill the community engagement requirement, the state has to choose a 1 or 2 or 3 month look back period to demonstrate that the person was satisfied that requirement 1 or 2 or 3 months prior to when they applied. So it's not just in the month they applied, there has to be a look back. And so depending on which look back the state chooses, the notices will go out earlier and earlier. And then the state has other obligations about when it notices beneficiaries. So upon enrollment, whenever there's movement in the eligibility determination process, if there's a hardship exception, that's different than a full exemption. A hardship exception is going to be a temporary stay, basically, of having to comply with the community engagement requirements. And whenever someone's eligibility is reduced, the state is federally obligated to notice them. And if CMS tells them to. Okay, so that's a lot of pressure put on the Medicaid program that's most likely going to reduce enrollment. The more Medicaid enrollment is reduced, the more people are going to be uninsured. We know historically from literature, from health policy literature, that when Medicaid beneficiaries become uninsured, they tend to stay uninsured. At the same time, there's another avenue that is pushing increased uncompensated care because of lack of insurance coverage, and that is the enrollments through the marketplace, like Jake was talking about. So that's, we call it healthcare.gov, we call it the marketplace, we call it the exchange. That's where people can buy individual products for themselves. They're called qualified health plans. And you can a person can get financial help purchasing that individual product if they only through healthcare.gov. So the issue is, or was, in the immediate years during the COVID pandemic, there was extra financial help offered by the federal government for people buying their insurance this way, as a way to really try to shore up that everybody who could stay insured did stay insured. That extra financial help, they're frequently referred to as subsidies. That extra financial help was available. It was deeper, it was richer, and it was available to more people. That extra financial help went away. It expired at the end of 2025. And for some folks, that meant that their insurance, their premiums, and their out-of-pocket costs were going to go up significantly. I don't know whether that's actually happened. These are preliminary figures from CMS that came out earlier this spring. And all I can tell you is that according to those public use files, there were 70,000 people from New Hampshire that enrolled in a qualified health plan in individual market in 2025. And that in that first quarter of 2026, it was down by 7% to 65,000 people. There hasn't been any additional release of data to see what happened since the formal end of the first quarter. The insurance department may have some facts and figures about that. I don't know. But folks here on the marketplace who are more likely to experience the financial pressure are actually people with higher incomes, so people at 300 and 400% of the federal poverty level, because the largesse that they got to experience went away, and they can make the decision to just not carry it anymore. And many people do. Okay, so this is all a very long-winded way of saying uncompensated care is likely to increase over the next several years. Copays began. There were additional copays for certain prescriptions in Medicaid. Medicaid in New Hampshire already had copays for prescriptions. They just were increased. In this year, we're likely to potentially see some premiums imposed on those CHIP families and expansion families. In 2027, work requirements and the twice-a-year eligibility checks, and then the copays in 2028. The stuff that's not bolded is that boring stuff I told you about, the state-directed payments and the reduction in tax bases. Those are really important and will also contribute to uncompensated care because it will make it harder to pay providers in other ways that Medicaid can pay providers, which is not through enrollment, but through increasing payments for certain kinds of services. Like, for example, when a state is having a great opioid crisis and wants to ensure that providers who are starting substance use disorder recovery services in New Hampshire are getting enough reimbursement to stay open. So a state directed payment is a legal way that the state Medicaid program can say to its insurance carriers, please pay those folks more and do it in this way. That's going to become more complicated. And the tax base for generating the non-federal share is going to become more limited. And the ability of the providers to go back a full quarter to get reimbursement for someone who only recently became eligible for services that they had already provided to that person before their eligibility determination was official, that's getting limited also. But again, that's another day. Enrollees mostly will not confront that. But what they will confront are healthcare providers facing a lot of financial pressure because there isn't a special hospital where only Medicaid folks go. Right? The providers that are losing folks with Medicaid coverage are also going to be the providers losing folks with individual market coverage, and they still take care of people. So they keep their doors open, they still pay everybody, but they get less money into the house. And when that happens, eventually they have to start making choices about what they provide and what they don't. So on that very happy note, I am going to end there. And
That's your New Hampshire easy slides.
okay.
Okay.
So if you are here or at home and you're like, how would I know if I'm in the stupid red slides? Again, it's called Granite Advantage. And if you have New Hampshire Easy, if you have that online portal that is the way through which you apply for your benefits with New Hampshire, including Medicaid, if you do it online and you have one of these accounts, this is what an account page looks like. You can go to benefits and you will see that it says Granite Advantage, right? It will tell you the eligibility group that you came in through. That's how you know it. You see Granite Advantage folks, they're the ones who are going to have to worry about work requirements and double eligibility checks in the next. For folks who do not have New Hampshire Easy, there's this thing that God created called telephones. You can just pick them up and call someone and ask the department to tell you which eligibility group you are in for Medicaid, and they will tell you. So you can find out in advance, because the really important thing is that you keep up to date with all of the changes, which is why it's great that Medicaid Matters exists and is here, because they can also push information out to you about when notices are starting to flow and generally what they say and what they mean. So keep your information with the department as up to date as you can. Contact information, maintaining accurate contact information between the state and the Medicaid enrollees is a challenge in every single state in the union, every single one. So even if you think they have it, make sure they have it. Okay. So thank you. And now I'm going to ask Dr. Walker to come up.
Thank you, thank you. Hello, everybody. I'm Cynthia. I am the CEO of the Mental Health Center here in Nashua. You'll see this on our slides. It says the New Hampshire Community Behavioral Health Association. That is the association of the 10 community mental health centers throughout the state. So all the things that I'm saying about the impact of mental health centers applies in every region of our state. So again, awesome sauce, you do it. So one of the things that people have been talking a lot about with Medicaid is the single largest payer for behavioral health services in our state. So a lot of that piece of pies, many of those folks come to mental health centers for care or other places like Harbor Care that provide behavioral health services. And as the safety net, community mental health centers, CMHCs, community mental health centers, we're the safety nets for mental health care, and we serve anyone who walks in our door, regardless of their ability to pay, right? And so we have a high proportion of individuals with Medicaid. Henry, you shared your stats, and FQHCs tend to be around 50% of people they serve have Medicaid. In community mental health centers, Some of the individual centers are as high as 80%. 80, right? So a change to Medicaid really impacts the CMHC's ability to how do we administer the programs, the infrastructure we have, our ability to have staff to provide all the services right now. And of course, it impacts the lives of all the people that we serve. But we're very resilient, mission-driven agencies, right? So we've adapted through Medicaid changes for centuries. Greater Nashua Mental Health has been part of this community for over 105 years, right? So we've been up in the highs and lows. So it's not that we're fragile and we'll close, but we definitely need policies that have stability to them, because that uncertainty, that change just really impacts our ability to grow, right? Like that pie and all those kids, right? And kids in New Hampshire. And what do we know about our kids right now? Many of them are in need of mental health services. But then if their Medicaid goes away, if that changes, we can't increase the services that we provide to those kids. So you can move it ahead, thanks. So the things that we're really monitoring, so in addition to some of the things that Deb mentioned, right? Some of these requirements are also increasing the demand for documentation on providers. So instead of spending a certain proportion of our time in direct care with people, now we need to fill out forms and help people do this redetermination twice a year now, right? Like for a provider, that takes us out of the space of providing services because of that increased demand, right? Sometimes those things are necessary, but then when it takes away, it can get a lot. We're also concerned that it's not people that don't need care that are at risk, right? Like everybody's at risk, including some of our folks who have a lot of needs for mental health or substance use disorder treatment. In our community mental health center, when Granite Advantage started, the biggest place we saw impact for that was in our older adult program. So people that didn't have access to Medicare for some reason now had access to Medicaid, and that was great. And the other was in our substance use disorder treatment services. And so changes to Granite Advantage are likely to decrease those two populations of accessing care within our shops. Now, all of this verification, I sort of like the idea that maybe it's auditable and the state has to figure it out. The last time we tried work requirements and medical frailty, I was in a different role. And so I literally still have spreadsheets and spreadsheets of tracking the requirements we needed to do to prove somebody was medically frail and unable to meet those work requirements. So really worried about what is that burden going to be for us, especially for us in the substance use disorder treatment space, but also in other spaces. So, are we going to be responsible for that verification? Are we not? What does that look like? Having lived through the last round, these are some things we're really paying attention to. Yeah, go ahead, Jake. Thanks. So these are kind of our unanswered questions that will really determine the level of impact on our community mental health system. So what makes this moment particularly challenging is that many of the decisions the state's going to make in the next 30, 60 days, we don't really know what they're going to be. And so until they are, what does that mean for us? So it's kind of hard to prepare, right? So will all of the major mental illnesses that we provide care for be on the list of diagnoses? Will they be able to use the claims at community mental health centers, at FQHCs, federally qualified health centers like Harbor Care, to automate exemption verification? Or are we going to be doing all of that paperwork? How frequently will the documentation need to be reviewed? Will we be or not be, be part of that process of certifying impairment? And then how will co-occurring diagnoses be managed? Somebody might have a low-level mental health disorder and a low-level substance use disorder, but put those two things together, right? How are those folks impacted if they maybe don't meet the list with one or the other, but when we put them together? So, I mean, really the bottom line for us, and I think for me, if you want to shift to the key takeaways, is the real risks for us are these increased administrative burdens and the loss of Medicaid coverage for vulnerable patients. So during the change that Deb mentioned, when Medicaid changed with the redeterminations after COVID, our uncompensated care went from about $1 million a year to 2.5 overnight when that change happened. The Office of Medicaid tried to give us lists and tried to let us figure out who was going to be impacted, and they weren't even close. There was maybe about 10% of the people who were ultimately impacted on the list that the state had provided us to be concerned about. So that means, right, massive uncompensated care. For us, it also means many people choosing not to have care, right? So even though we see people, even though they aren't able to pay, like many of us, many folks don't want free care. They feel it's a burden, or they're not sure, is it actually true? They don't trust it. And so they might not even show up for that care, right? So the greatest opportunity in this that we have, and one of the things we're really talking with DHHS about, is what is the opportunity for the state's design for that verification process? What will their recognition of mental illness be, of co-occurring substance use disorders? What will that be? So we are resilient. And just like everything else in our state, we rely on policy stability. So we're here and we want people to keep coming. So we don't want folks that fall off the rolls or who are worried about work requirements not to come, because then that has other negative ripple effects on the system. And we need everybody's help in understanding that this very system that we keep talking about needing more of is really at risk with some of these changes. That's all I have to add to the conversation until we have questions. So I'll give it back to you.
Thank you so much, Dr. Whitaker, and thank you, Deb, for these important perspectives, all this information. I'm sure the two of you are like me when you go around talking about this. I feel like I should have a rain cloud over my head all the time, right? With a bad news crew here, right? So now we'd love to invite all of you into the conversation. I'm sure, like me, you have many questions. So our friends who are with us online, please can enter any questions into the chat. And for those of you who are here in the room, please just wait on the microphone so we can make sure everyone can hear you.
Don't be shy.
Don't be shy.
This is sort of a really niche question, but it's my understanding that children who were foster kids that were later adopted still got CHIP coverage, even though they were adopted. Do we know about the premium impact on those kids? Will the state continue to pay that coverage, or will their now parents be responsible for paying for their healthcare coverage?
So that's a great question. One of the silver linings in this is that kids in Medicaid right now have something called continuous enrollment. That Medicaid, as of, I want to say 2023, is required to give kids 12 months of uninterrupted coverage, regardless of whether or not something happens that interrupts their eligibility. So technically, I think one of the reasons that the state is tinkering with the timeline for implementing those CHIP premiums is that it can't have any impact on their eligibility. They have to keep them enrolled. And so the question is, are they going to delay the implementation, or are they going to sort of keep those charges in abeyance because they won't be able to disenroll children because there's an overriding federal law that says they have to stay enrolled. And technically, within the confines of Medicaid responsibilities. Medicaid programs are not supposed to be able to disenroll someone for failure to pay. So all to say, maybe, but actually, no. I think the answer is they can't disenroll those children. And non-payment should not result in them being disenrolled.
Anyone?
Other questions, comments, perspectives?
So the recent numbers from DHHS in the last quarter is that it's taking approximately 87 days for a determination of eligibility. The retroactive plan brings you down to potentially 30 days. But if New Hampshire Medicaid can't make an enrollment decision in that 30-day window, how can there only be a retroactive date of 30 days? We struggle currently with retroactive payments.
I don't have a good answer because it's federal law, like it's not, there's not an option, right? It's going to be what it's going to be. Even recognizing the difficulty that the state sometimes has with making prompt eligibility determinations. The good news there also, I will say, is that it is a priority, making eligibility easier for the department. They had to hire a vendor, PCG, to clear the backlog for long-term care eligibility, and they are working through that. And they've adopted some new processes to improve eligibility timeliness. So I'll also say there's some improvements that have been made, but there's no give on the other side. It's federal statute now.
Thanks, Doug. Back to the $35 copay,
Yeah.
you said 2027, is that correct? 2028?
Yeah.
Is there, how is that list determined? Is it predetermined?
So in the statute, there was a number of services that they exempted from the co-payment. I didn't include that in my slide deck, but we can absolutely get them to you. No problem, but they really tried to exempt behavioral health, substance use disorder, primary care, OB/GYN care, and any services that provide an FQHC. So
It's a defined list.
it is, it is. I mean, insofar as anybody has a definition for primary care,
You know,
which I don't know, I mean, but no health policy person on the face of the earth has, there's not one, sorry, folks, there's not one consistent definition of what is primary care. This is how health policy people spend their free time.
My question is to tag on to that, which is regarding those copays. Can you give us an idea, number one, of what would fall under that requirement? Because it sounds like there's a whole lot of exceptions, so I guess I want an idea of what would fall under that. And two, for the $35, that's a maximum, right? So there is, the state could pick cost share. I think that
That's a great question. I don't remember if the language says up to or if it says shall be $35.
I believe there was a piece of legislation that tried to do that, so I just want to clarify that.
That's a great question, right? Like, is it up to or is it shall be? And my guess is that if it's based on anything like value-based insurance design, that the services around which the co-payments would apply would be things that are considered low value. But that's always in the eye of the beholder also. Right? Like, we want people to get behavioral health care, we want people to get preventive health care, we want people to get primary care, we want people to take care of the babies and the moms. So is everything outside of that low value care? No, certainly not to the person receiving. So that could be specialty care, it could be therapy, yeah, PT, OT, ST, it could be eyeglasses, et cetera. You guys ask good questions, I have to come with my actual statute next time, I'll be like, oh, please,
Back in the corner,
just stand right back here, ask
Yeah.
a question. Or
What,
a comment.
how the heck realistically are they gonna track this? I mean, you're actually putting the burden on local nonprofits, right, with these work requirements. They're gonna have to hire someone just to simply do this. Let's talk about the reality of it. There's the condition, you know, we could like condition A.
Yeah.
Condition B.
Yeah.
So I have a substance use disorder, but what documentation now?
Am I gonna be, if I'm in year
To
three,
see if I
right,
meet that criteria, but I need help now. But yeah, I didn't meet my word.
I think that's
like,
right, I think that's part of,
to me, just looking at it, like, you know, logically, it seems like it is. And
I mean,
I don't even know how to wrap my
that,
brain.
right, Dr. Whitaker was alluding to this in certain respect, that everyone is waiting for the details. The tables that I showed you, those just came out on June 1st. Every state in the union is looking for those details, and now they're trying to build systems around those details as they understand them, to try to get to a place where they could communicate all of those details and what you need to do to fulfill them, and get all that out to providers and beneficiaries before the new year. So it's going to be hard, no matter what happens. The state can apply for a 6-month stay of implementation. I have not heard any discussion of that, yay or nay. I haven't heard it either way. I do know that what they have been working on is a way to, in the most automated way possible, identify people who, under the old definition of medically frail, were medically frail. And now they're having to rework even that system, but now they have to add on another one. It doesn't just identify the diagnosis, but then looks for the evidence of the impairment. And they have to create their own rubric of what all that means. So it's absolutely complicated. Byzantine, really. So it is going to be hard. There's no way around that. I do think the state is working as diligently as they can to try and get their arms around it and make as much sense as possible.
You know, and there's the thing about, you know, people that are deemed ineligible because they're like, are they gonna have to? I remember there was talk like, you know, 8 years ago, like 2018, well, then they have to show like 3 months that they're back and
Yeah.
like,
Yeah.
what, before you can even be re-enrolled? I
Yeah.
mean, there's what?
I just want to reiterate a point that we are in frequent contact with our friends and partners at the Department of Health and Human Services. You know, every indication we get from them is that they are truly committed to making this as user-friendly and as easy on recipients as possible. They're trying to find every possible way to do that. They talked about trying to use payroll data to be able to more automatically determine who, you know, who's meeting the work requirement, who's not, and so on and so forth. I think that the details that were just released on June 1st and have complicated that to some extent, and they've had to, you know, kind of adapt the way that they're thinking of their systems, but I have no doubt they remain committed to doing all they can. It really just comes down to the question of how much they need, right? And I think, you know, as Deb mentioned earlier, last time we tried this in 2018 or 2019, of the people who are going to be held to the work requirement, you had said 1/3. I thought it was 12, but it was 2/3 of people who are on pace to lose their coverage.
Oh, no, 1/3 we knew for sure was
Yeah.
on pace to lose their coverage.
Right.
Within,
And so, you know, and that was after the state spent a great deal of money and a great deal of time and effort to alert people to what was coming. So again, certainly I think our partners at the state are committed to doing everything they can. I think there are limitations, there are going to be limitations to what they can do. And again, we're here because we're really fearful about what the impacts of that are going to be, both on individual recipients and the providers who serve them, for sure. On that super bright note, are there other questions?
Just a question for Dr. Whitaker. You know, we know that people who are in mental health crisis or, working on their recovery sometimes have starts and stops of treatment during those opportunities. We know their mental illness or their substance abuse disorders do not stop during that time, but the documentation might stop of treatment because of starts and stops of service. So I just wonder if that's something that the community mental health centers might have concern over.
I mean, that's exactly one of the things we're worried about, right? So like, what's the look back of the services that they're looking at? Is it over the past year? Is it over the past 3 months? Like, what is that time frame? Because you're absolutely right. Just because somebody doesn't show up for services doesn't mean they're not available and need those services. So I think that's one of those like unanswered questions that we have, right? Is what is that look back period? And is there a way to override it? Like, because sometimes we're providing services to individuals that don't make a claim. Because a lot of some of our outreach efforts are not billable, so Medicaid never sees the claim. But we might be having still contact with those individuals. So how do we work with the department, which is why we need to stay engaged with the department about reminding them of those things. So hopefully maybe we're creating some claim that goes to Medicaid that's zero bills, but at least helps somebody stay enrolled. I don't know, right?
Yeah.
You talked about in the granted advantage population, the premium increase with the lack of subsidies.
Yeah.
And you had a range of, like, I think 60 to 100.
Yeah.
Is that pretty typical? Is there a median there, and can it be higher? I mean, we heard scare statistics.
So I don't have any data about what the premiums are in the individual market now with commercial insurance. A person can buy a bronze plan and have a zero premium insurance product, but then they will have a sizable deductible. So there may very well be people in the insurance market that have a $60 to $100 monthly premium. In Medicaid, which is where those premium certificate applies, that's unheard of. Generally, people are not charged premiums because they have such low income. And Medicaid doesn't traditionally want people to shy away from coverage or services because they're worried about out-of-pocket costs. And even tracking them, the state has an obligation to track how much someone pays out of pocket. They're not supposed to pay more than 5% of their annual household income towards a premium or copay if they are a Medicaid enrollee. But again, this creating a system, funding a system, making sure that it operates, about how you track that is another complication and another expense for the state.
Anybody have any good news you want to share?
It looks like there
There
were
were snacks.
crackers. Yeah, eat some of the snacks for sure.
Any questions that are coming up?
No, we're good.
Then I think unless there are any other questions or comments, we are going to begin to wrap up. But before we do so, we are going to
Do you want me to advance slides for you? Or one of us? Bianca's gonna do it, so I can take some photos.
before we have our requests are asked of you. You didn't think you were going to get away with us putting something back on you, right? Yeah, so as I mentioned, our coalition is out here holding these events, and we're trying to raise public awareness. We're really trying to, for lack of a better term, build an army of people who are prepared to talk about the importance of Medicaid and talk about the threats that these changes to Medicaid are going to have on themselves, their family, their friends, their neighbors, the clients that they serve, patients that they serve. I will say that we are, to some extent, as we talked about, because some of these things, many of these things have been passed into federal law, our hands are somewhat tied. But there will be some steps that we as a state could choose to take that may not, fully avoid the negative impacts that are coming to us, but maybe it can cushion the landing, right? I think that there are safeguards that we can put in place. There are things like creating an uncompensated care fund to help some of our community providers offset some losses that they're going to experience, right? There are things like restoring a navigator program. So that we used to have a navigator program in place in the state to help people who are having challenges with insurance address those challenges and be able to maintain or secure insurance coverage. So those are things that the state could take. Those are two examples of steps the state could take to make things a little bit easier for our healthcare providers and for the people that they serve. But these things require investment, they require funding, they require resources, and to get any of that, that requires voices. It requires our lawmakers hearing from people in their community about the importance of these issues that we're talking about the impact that these changes in Medicaid are having on their friends, families, and loved ones. So that's what we're here to ask for. We're here to ask you all to work with us to raise your voice, to bring attention to these issues that are rising within our local lawmakers. Thank you so much, Representative Zalewski, for being here today. We hope to continue to engage you and all of your colleagues on these issues. We know this will be a hot topic when the session starts next January. So by being here with us tonight, by registering with us, you have signed up for our email address. You can look out for ongoing communication from us to alert you on sort of changes, updates on these changes as they come, and also what opportunities there are to speak up, to advocate, to use your voice to try and influence our public processes as we again try to cushion the fall here a little bit. So, next slide. If you are on Medicaid yourself, if you know people on Medicaid, you can share your story with us. We say oftentimes, and certainly Representative Zalewski can speak to it, there's nothing more impactful in changing the minds of our lawmakers than when they hear stories of individuals who are directly impacted by these changes, by the individuals themselves or by people who help them, who serve them. So we are always looking to collect perspectives and stories and thoughts about the importance of these programs that we can help to pass on to our lawmakers to make sure they're aware of the real impacts this is having in their own communities. So please, if you have stories to share, thoughts on perspectives to share, please share them with us or help other people do so. We have story collection forms, all the information you could possibly need on the coalition website, which is nhneedsmedicaid.com. I think that might be on the next slide. We have social media accounts. We are on Facebook and Instagram, so you can catch updates there and opportunities to engage with us. And again, our website is nhneedsmedicaid.com. So. Our friends at the Department of Health and Human Services, who we've talked about so much tonight, recently launched recently updated their webpage related to Medicaid and many of these changes that are coming. So there's lots more information available there. Following this QR code, or if you just Google DHHS and Medicaid, I'm sure it'll come up. So if there are more specific questions about your own circumstance, I have no doubt that there's more information available there that can be helpful to you.
It's also in the packet.
It's also in the packet.
Good. Jake, before you wrap, we have a question in the chat, and I think Deb can probably address it. If you're currently unemployed and are unable to find a job before 1/1/2027, will you lose your coverage? And are there any exemptions for folks who are trying to get a job?
So seeking employment is a activity that will go towards satisfying the work requirement, but it can't be only that. It will need to be a combination of seeking employment and volunteering, community service, education, interning, so working for no pay, which I know does not help the person who needs money to live their life. But there are lots of ways to stitch together satisfying the work requirement, at least according to the guidance that we just received this month.
Right, so unless there are any other questions, I want to thank you all for being with us again. Thank you for your attention. Thank you in advance for your advocacy. We really look forward to working with you. And again, if you take anything from tonight, know that again, Medicaid is not just important to the people who are on Medicaid. It's absolutely critical to our entire healthcare system and to the health and well-being of all of us. So thank you for your time. Thank you for being here, and thank you for the work to come.